So just while Dr. Ashraf is sharing, we'll have Dr. Ashraf present some cases, and then we're going to have a little bit of a workshop. We've got some very interesting cases that I would like to show you as well.
It is edible, it's visible and edible.
Yeah, visible and audible, sir. Thank you.
Shall we start?
Please go ahead.
Okay, thank you. Good evening, everyone. Today I will share with our colleague the case of bronchobrain dysplasia. This patient is 25 week gestation. It born in July 9 July 20 and charged from hospital December I think 20 December also 20. We stay 4 months and 10 days. Really, this is the cases of with for what for you, I face all morbid comorbidity in the RDS. She is delivered at due to emergency CS, the baby inactive in labor, breast presentation, no steroid or magnesium sulfate. The birth weight was 610 gram, intubated and sulfate given in OT. First ultrasound done after 26 days. He went to the following morbidity. SIB after 10th day, it has synthetic perforation. Go to the ostomy and then secondary anastomosis. Went to BBD and charge home without oxygen. Went to RO based 3 plus disease. He gave intra fetal avastin injection twice. Alhamdulillah, it is good. Save the eye. Grade 2 hemorrhage and regress on discharge. Neonatal sepsis or improve. We start the image. The one in the screen. This one is in 26 days at 28 weeks. It was in August 4. As you see, I make this only one right lung. It's all white lung with extensive atrectices. R lower the same. R1, R2, and the R3. Is still intubated with to about 1 month and a half. After 7 days, the 1 week, they still have the same, but the progression better than the previous one. AIS, sick borderline. At least there is no more attacks like this. Now البلورة بدأت تبقى feasible انها sick ولارج. So في some plexuses white lung here. I repeated after at 30 to 32 week. في more aeration والبلورة line smooth regular. Some aeration there. Here the X-ray in first one. After progression increasing. This is last one. This is in 32 week. We'll continue.
Yes, please.
At,
I'll just rub that.
at 33 week, still line ABB profile with abnormal pleura. Here. So at least there is some aeration
Yep.
much better than before.
Completely agree. Yep.
Yeah. At 35 week, now more aeration. Even the X-ray more better. At 37 week, more and more aeration. At this time, it will be in non-invasive blood support.
Yep.
At 39 week, more aeration بس still في white B line بس aeration more better in the most of the area. the same AB profile at fourth week, more aeration, more air, more يعني less fluid and more air. And this is the one, the last one before the charge. يعني more or less complete normal bladder, regular pleural line,
Yeah.
A profile. See, it's good A
Yeah,
line here.
very good aeration, especially
Yeah,
left and middle images. I mean, it's a very
yeah,
nice example of really good progress. And I think for everybody here, one of the clinical kind of parameters that we monitor often is the B profile in AIS before and after starting diuretics. And I mean, Almenina has just recently published her work, but in terms of actually seeing an effect, it takes about, I would say, 24 to 48 hours. Within 48 hours, you can actually see the interstitial appearance, getting better. The question from our perspective is how bad it was and whether it moves from a complete whiteout, as you might see, to kind of compact B lines, which is improvement, or if there were previous compact B lines, whether they move to kind of an AB profile where you start seeing double lung points. Often the pleural thickness will not change on starting diuretics, but actually when you start steroids, it's quite interesting. The
yeah.
aeration and even the pleural thickness can sometimes improve. There's a very nice sign on your one of your initial images. So if you could go to your first image. Thank you so much.
This one. Yeah,
Yeah, yeah. So just in the corner, you see a fractal sign appear at some point there. See?
yeah, yeah.
Yeah. And again, it's for all the participants here, it's really important. The fractal sign has a high sensitivity for diagnosis of sepsis, but it is not unusual to see a fractal sign in meconium aspiration uh, after a pulmonary hemorrhage where you've had significant destruction of the lung parenchyma, and you may have babies who've had chronic lung disease evolving, but they might have had previous infection, and if they've had previous infection, antibiotics, the fractal sign takes a long time to resolve. Now, it may be that you've had a colleague treat a baby for sepsis, often trying to determine the source of sepsis. Is it the lungs? Is it pneumonic kind of presentation? Is it gut translocation? Now, you may pick up a fractal sign later on while the baby's well. And again, clinical correlation is quite key. I mean, if this is a well baby who's actually improving, uh, where you've done a scan for monitoring chronic lung disease and you pick this up, the fractal sign in isolation, if the baby is completely well, might prompt you to do bloods. If the CRP is normal, I would say just in one isolated sign alone, I wouldn't necessarily be pushed into starting antibiotics. So again, the clinical correlation is quite key, but it's very, very nice images. Uh,
Dr. Alok, I
yeah,
think يعني most meta-analysis and review article confirmed the ultrasound can predict الBD at 14 days. Why I shall wait to 36 weeks to start the treatment? يعني in this cases, I 34 week I started steroid and diuretics and even the bronchodilator. Why
uh,
I still
yeah.
I wait 10 weeks later عشان I will start? Why from the beginning I will start?
Uh, I I think it's based on progress of the baby is the approach we take. And I mean, if a baby's weaning well, coming off, I mean, nutritional kind of rehabilitation probably for us is the key step. And then it's really if we're stuck on non-invasive ventilation, what we normally do, and it's a little bit early, I'll be presenting this later on, is we take an approach of trying to evaluate the reason why we're not able to move the baby forwards. Now, that does involve doing serial lung ultrasounds, but also often doing an echo to kind of quantify whether there's an element of pulmonary hypertension or duct, or
Yes,
you might
yes.
have, another left to right shunt. Uh, and then really The other things that we kind of think of in situations like that is whether or not you can test for things like ureaplasma. Now, I know that in certain setups, ureaplasma has a higher incidence. I must confess that in the UK, the challenge is it takes 2 weeks for us to diagnose, and by that time, we've probably missed the boat. So often we start empirical treatment with
Yes,
azithromycin.
yes, that's what I do. I start azithromycin like this. That's cases. Yeah.
I think the debate for bronchodilators is, I think if there's audible wheeze, we start, but to try and get them off non-invasive respiratory support, I worry about the risk of selective dilatation of the upper airways. And
If not,
actually,
not for edge cases, يعني just one severe letter like this, stay about almost once in ventilation,
sure, sure.
another 1 month in the non-invasive. ف- As you said, by nutrition, increasing the nutrition with calories intake, get better.
Any questions for Dr. Ashraf? Anybody? These are very nice images. Dr. Ashraf, do you have another case?
Yeah, we have RDS, so it's
Please, please.
thank you, Zaman. Feasible now? Feasible?
Yes, visible. Yeah, you just have to go to
Okay.
slideshow, I think. Yeah.
Yes, okay now. There is a preterm female neonate, 25 weeks,
You're not on
delivered,
slideshow, Dr. Ashraf. I think you're still sharing the old presentation. So you might have
not shared till
you
now.
have to stop share, close the old
Okay.
presentation. Yeah, lovely. Thank you.
I will get again طب me بس minute كده عشان I will get the video. The
A-
video
a-
will,
any questions of BPD while Dr. Ashraf is bringing the video slides up? Any questions on BPD and lung ultrasound?
feasible now?
Not at the
Feasible?
no. Does anybody else have any peer review that they'd like to share?
Yeah. Yeah, feasible now?
Uh, yes. Yeah. Thank you so much. Just have to go to full
Okay.
slideshow mode.
There is a
Lovely.
preterm female, 25 week, delivered in 22 February last month. Intubated and OT and give first dose of Servanta with a weight of 485 grams. It's mother primary graffita with hypertension on treatment, graphited by lower section section. No material risk factor for sepsis, no steroid. السنابي after 12 hours it was 94, it's very high. I repeat again after 48 hours it was decreased to 56. It might mean this is good predictor for the outcome. It started in BCAC mode with volume guarantee. Now with the SIMV mode with volume guarantee. Ultrasound done after 10 hours from the first dose of Servanta to check is need another dose or no. You hear me?
Yeah.
This is X-ray on admission. This is the second ultrasound after first 10 hours after the first dose of Servanta. Still the snowflake signs will abnormal pleural line with subclinical consolidation, white lung. Here, white lung,
Yep.
abnormal pleural line, subpleural consolidation. Lateral view, it is AIS with برضه compact V line. In right posterior also في small snowflake signs with micro subconsolidation. السكور here 7.
Yep.
يعني this is 2. يعني this is it takes 3 2 2, 3, 2, and 7 for all.
Yep.
The left lung,
Oh dear. Yeah. Mm.
the same for you, bilateral pathological homogeneous disease. The برضه abdominal pleural line sick, snowflake with subclavicular consolidation, and L1 and 2.
Yep.
L1 and 2 is the same. Snowflake signs, subclavicular consolidations. Lateral is the same. White lung with AS. Will posterior also the same. I put the posterior segment
Yep.
found is not atrexisis. So also the score 7. Score 14 now.
Mm.
I give another dose of Cervanta وكنتوني على اس اي ام في.
Yep.
After 10 days now with there's a score 7 7 and 14. After 10 days I repeat the ultrasound to check what happening, and we'll try to make an score for the BDA for BD to BDA. Now more AB profile, more
Yep.
aeration.
Yep.
الرئة lateral يعني برضه في aeration بس still ABV. I make this because there was classic scoring for BDA for another score called modified
Yep.
with the same the classic one بس an additional retrohepatic screen and retrospecific spleen.
Mm.
فالسكور في الموديفايد 24 في الكلاسيك 18.
Yep.
I make both of them to be sure. يعني this one in the classic score 4. يعني هنا 1 1 2 this 4
Yep.
1 1 2 and هنا all 2 this 6.
Yep. Very nice lower image. So for those of you, I'm just gonna use it because it's a really good teaching slide. So what you can see very nicely over here is the curtain. So this is diaphragm, that's lung, and naturally this is the liver. And if I just rub everything out, what you can see is you can see the medial margin of the diaphragm, but then the lateral margin gets covered by the lung. And this is classically called a curtain sign. Now, if you have fluid in this area, then the fluid will basically cause compressive atelectasis of the lung, which kind of then masks this curtain sign. Now, I sent you an image for homework, everybody. So we're going to have a look at that image just after Dr. Ashraf has presented, and I want to pick your brains on what you think it is. Go for it, Dr. Ashraf. Thank you so much.
The left lung more برضه irritated more than previous first scan, second scan. AB profile هنا B profile في الديستروي سيجمنت والسبينيك اولسو تك 2. هنا السكور في الكلاسيك 3 والموديفايد 5 يبقى توتال سكور in the classic 1 7
Yep,
means mild والسو في الموديفايد 11.
yep,
ال 11 also mild. from modified from 14 to 16 moderate, from 16 up to 24 is severe. Till now, at the 10th days is mild predictor to mild BBD. I will see بقى what happened will first. شغال next week.
What is the baby's current respiratory status at this time when you did the scan clinically?
ان اس اي ام في اللي هو تارجت فوليوم 2.4.
Sure.
تارجت فوليوم جراتيتي 2.4 يعني تقريبا 5 ام ال بر كي جي.
Yeah.
Gaining weight maybe 30 grams this last week on TBN. When I start feeding now, reached 10 ml for him. It is full fed.
Hmm.
150 per kg. We give him 120 calorie.
Yep.
No antibiotic now. We'll try that to see what happened.
Sure.
There is no hemorrhage till now. Alhamdulillah, no, I make 3 scan. No hemorrhage, no intracranial hemorrhage.
Yep.
It is early to extubate this baby to try to put in non-invasive. Now the weight 500 520 grams.
Hmm.
I try to wait another 1 week for ventilation. بعد كده I will try to in NIV. I will try.
What are you using for your NIPV over there? Your NIV? You
I using Draeger
you're
also,
using the
Draeger.
Drager.
Yeah. The other one has up to flow nasal bubble CPAP. Can I have Genefrey from Italy? First one down, non-invasive. It's not try to make maintenance. Not working now.
Mm, mm,
But I usually I work in the BV. I like and I put it in the wool trigger. In the same ventilator, I make extubation. I put in NBV
sure.
for 2 to 3 weeks. I keep in the CPAP. I keep beep till 32 weeks.
Very nice images, Dr. Ashraf. I mean, I'd say you've got really good depth, very good delineation. Carry on, please. Yeah.
Yes, is this the score? Yeah, this classic. In addition to the classic, retrohepatic and retrosplenic.
Yep. Again, very nice curtain sign that's visible over there for everybody.
Mm.
It's a sign of normalcy. Excellent, sir.
This is for today.
Yeah.
Thank you.
My pleasure, and God bless you. Thank you. Your
Thank you.
your images are absolutely amazing. I thoroughly enjoy them. I am keen because we've got a good small group today to have a workshop, uh, which basically
Eh,
means that we're going to put everybody on the spot. But before that, I wanted to share one of my homework images with everybody today, and let's see what you think. Okay, now it's not going to let me minimize, but let's see if we can. Is that far back? Sorry, just giving me a little bit of trouble. Okay, so I'm just going to share my screen with you. So can you all see my screen?
Yes.
Lovely, excellent.
yes.
Okay, can you see an image on the screen?
Yes.
Yes.
Okay, so I'm just gonna see. So Dr. Ashraf, I'm gonna let the others have a think about it, but we've got Alberto and we've got Friedrich. So what do we think about this image? So if I tell you that this is a 3-day-old baby,
Mhm.
and this baby basically came in from the postnatal ward with a cyanotic episode, uh, just was blue, has very mild respiratory distress. The background history is that the baby had and was feeding and then had a kind of a coughing episode and became a little bit blue. So the mother thumped the back a little bit, but naturally got quite anxious. So the midwife's called, and the baby's just clinically been reviewed. Uh, has no respiratory distress, has a clear chest, but because of the cyanotic episode, the plan was to do a chest X-ray to see if the baby might have aspirated. And we've done a lung ultrasound in between. Now, if I say to you that all the images, R1, R2, L1, L2, basically show a normal A profile.
Mhm.
But when you look at R4, you pick this up. So I'm just curious. I'm curious to see. I'm going to ask Alberto first. Alberto, what do you think
Okay.
is happening here?
I think we can see the curtain sign. We can see the diaphragm. We can see the liver, and we can see the bottom of the lung as
Ve-
well.
Okay, fantastic. That's one thought. Okay. What do the others think? So I'm just
Yeah,
curious.
I can see the pleural line as
Yep.
well.
Yep.
I can see some comet tails or just a few B lines, and probably it's I don't. I think it's A lines and not not pneumothorax. That's what, because you have cometal sign, and
So you've
that's
got,
why the presence of the pleural sliding is okay, isn't it?
sure. So on the left, you're right. You've got this thin pleura. You've clearly, from our perspective, got what I'd say is maybe the odd comet tail coming in.
Mhm.
And just trying to see if I can open my marker, if it'll let me. It won't let me today, unfortunately. Annotate. So really what you've got on this side is pleura and an A profile with the occasional comet tail.
Mhm.
You happy with that?
Yes,
Okay. And then you kind of have,
the diaphragm.
okay, excellent. Anybody else have any thoughts?
Little bit the skin is thick.
Yep. He's quite a chubby baby.
Yeah.
Okay.
So can we see a batwing?
No,
No.
we can see air in abdominal air. No,
Okay.
because we don't see any battering, and it could be
So
no.
with the eye of faith, that's one rib.
Okay, okay,
That's another rib.
okay.
And this is intercostal space. But actually, as you come to this side, there are no ribs visible at all.
Mhm.
So anybody else with any thoughts? So we've Alberto's given some really good thoughts to us. Anybody else?
Abdominal air.
Okay, it's on the right side. So on the right side, you tend to get liver.
Yeah,
So, abdominal air would be a little bit unusual. And usually,
yeah,
if you have abdominal air, you kind of get what is a very marked kind of an A profile, multiple.
yes.
Anybody else, guys? Satish?
Is it like a flail chest? I don't know.
Okay. Not quite I mean, it's a baby who's completely kind of asymptomatic now after a single episode. So Alberto is absolutely right. So this is where we have to be a little bit cautious in how we interpret. The reason I'm showing you this is classically what we call is a pseudo lung point. Now, a pseudo lung point is what is called a lung point mimic. So it's not a true lung point, but it can easily confuse people to think that there might be a lung point there. And the most important thing is sticking to the protocol of trying to identify whether you can see a batwing sign uh, and or whether it's absent from a certain area. So what you've got is you've got lung that's coming in. That's basically, if you remember the image that you saw with Dr. Ashraf, where you have the curtain sign, this is actually diaphragm that's coming in and going down. You can't see the liver yet, but if you went down a little bit more, then really what you'd see is you'd start seeing liver with this intervening area, and you'd actually lose this area of hyperdensity. And the reason it's like this is because we're hugely magnified. Actually, you've lost the superficial part of your soft tissue up here. Uh, you've got a lot of, I would say, soft tissue here. And classically, what you're seeing is the curtain sign where the lung basically overlaps the diaphragmatic margin. And this is one of the reasons of what is called a pseudo lung point. Does anybody have any other differentials for a pseudo lung point? Any other thoughts of why you might get a pseudo lung point?
Maybe in case of neoprotoneum.
Yes.
So yeah, so again, you're absolutely right. On the left side, and your anatomy and your correlation is very, very crucial here. On the right side, you get liver. On the left side, you get stomach. And what you might have is you might have lung that's basically overlapping the diaphragm, followed by what is a complete A-dash profile on this side over here. Because actually, you don't have a bat wing, but you have air in the stomach.
Mm-hmm.
The other reason you might get it is if you have a pneumoperitoneum, and that you can get on both sides. And I mean, Dr. Ashraf has shared some images which I will borrow and repost in the WhatsApp group, which clearly show that very nicely. But just remember that be very careful when you're trying to look for a lung point, especially when you move into the R3, R4 regions, because you might see a pseudo lung point. The other reason that you might see a pseudo lung point is if you can see me, I'm just going to start my video. So if this is your probe, just remember, if you have gel on your probe, now a very classical example is you've got gel in one area, and that gel basically is allowing you to provide an interface, which basically gives you lung, but you've lost contact in the other area, and you're not seeing good sliding. Now, naturally, as the lung moves, it might give you the appearance of pleural sliding. But more importantly, if you do a bar kind of look for an M mode, you might get what is a false barcode sign in the area where you don't have contact. So just be very, very careful. Again, your clinical correlation is key. Small areas, anterior pneumothoraces, with experience, with time, you will get very, very, I would say, experienced at finding small pneumothoraces, which Nadia basically calls a bubble. And especially in the early period of transition for babies who've had PEEP, and we've seen a lot of quality improvement projects where people give up to 30 minutes of PEEP. Near the medial margin, again, if you're looking at me, of the lung on the right side and the left side, near the thymus above, uh, it's quite common in those babies to have very small air leaks or what are called bubbles. And beware, we do not make diagnosis of pneumomediastinum using lung ultrasound. At least at this particular point, there are no clear-cut definitions. So if you have a baby who has ongoing respiratory distress, but has a classical A profile, and we have a lot of babies who perinatally adapt who have a lot of respiratory distress, they may have classical A profile everywhere, transitioning lung. And you might actually think clinically that this baby has got TTN because you have a double lung point, you have transitioning lung, and you have an A profile alternating with a B profile, but with disproportionate respiratory distress. Now, your clinical examination is key because if you have faint heart sounds, then that might be a giveaway that you've really got a pneumomediastinum. Or, what I'd say in those situations where you have disproportionate distress and the lung ultrasound is not quite giving you that information, please get a chest X-ray. I can't emphasize enough that that kind of dictum, I know the units in China, I know that the units in Paris, they're very experienced and they're very, very good at what they do. I think it's really important that if you kind of don't get an explanation from your lung ultrasound for the exact cause of a respiratory kind of pathology in a baby who's got a high CO2, where it doesn't add up that this might be respiratory or a neuro kind of muscular or an alternative cause, I would say still consider getting a chest X-ray done. There have been cases where we picked up, pneumomediastinum. We've picked up a baby who basically had a very small diaphragmatic hernia, which was very difficult for us to diagnose, because the loop of bowel was so low. It actually was more obvious when we actually did the chest X-ray that it was a small Morgagnian hernia. So again, your chest X-ray might be very, very important. Any questions about this?
No.
It's okay. Thank you.
Okay, so I'm just going to share a few slides. We're going to go through just 3 cases, but obviously we're going to get you to do a little bit of the work. So I'm just going to stop my share. Just opening my PowerPoint. So is my PowerPoint visible to you?
Yes.
Okay,
No.
it's not visible?
No.
It's not in the presentation mode, Alok.
Okay, my apologies. Now is it visible?
Yes. Yes.
Okay, excellent. Okay, so what I'm going to do is I just want to, again, in this workshop, emphasize the importance of having a structured approach to how you approach any kind of respiratory distress. And today we're going to focus a little bit on near-term and term babies, because really the age of presentation, the clinical history behind presentation are quite crucial. And really what is important is that you take into account whatever history there is available, the antenatal history. You might have meconium. Is this an elective cesarean? We don't give steroids these days for a lot of the near-term babies because of the neurodevelopmental worry. Uh, Again, are there risk factors for sepsis? But more importantly, if this is respiratory distress on day 3 or day 4 of life, well, what clinical course has this baby taken? Is this a term baby who had a little bit of RDS, who, I mean, theoretically, from our perspective, was CPAP'd on a PEEP of 5, 6, was getting better, and you have a sudden clinical deterioration on day 2? Now, the key thing from our perspective is if you think about pathology in these kind of near-term babies, really, I would say that clinically transient tachypnea of the newborn is a diagnosis of exclusion. And the reason it's a diagnosis of exclusion is because what you're doing is you're following that baby up clinically. For any baby who has respiratory distress at birth, a near-term baby who's needed respiratory support in the delivery room, even in the absence of risk factors, really any of these diagnoses could be one of the differentials. Now, your clinical index of suspicion for meconium aspiration becomes higher if you've got meconium in the mix. But we know so many babies where we've had meconium, uh, but where they might actually simply, from our perspective, have lung fluid, which is gradually going to clear. Or you might have babies who really are near-term elective cesareans who actually have RDS, or an infant of a diabetic mother where you have a little bit of immaturity. But again, what I'd say is that if you kind of have a clinical presentation where everything, your CO2 is normal, you don't quite have cardiac features, maybe this is just elevated pulmonary pressures that are gradually improving. Irrespective, it is the clinical course in correlation with your antenatal history, your clinical presentation at birth, that will kind of guide you as to the diagnosis, followed by biochemistry if there's sepsis. Now, the less common causes of respiratory distress that you might have, that a lung ultrasound might not necessarily always help you pick up, are the congenital causes. And Nadia will be talking to us about some of the congenital problems. And what I'd say is that if you kind of have a pattern that you don't understand, something that is creating, I would say, dropout. And a good example that I'd like to give you is for those of you who head scan, if you have large areas of dropout on your head scan and are really struggling to get images in the lateral areas, because the hemispheres are, a subdural is a possibility. But if you get a very similar kind of a presentation on your lung ultrasound and you can't make head or tail of it, really my advice would be to get a chest x-ray. And it's not unusual then in those situations to sometimes pick up some of these diagnoses that you have over here. CDH, again, just be very careful. Postnatal CDH may have a very small number of loops that are actually in the chest at the time that the respiratory distress is a problem. I'd also like to say to you that the diagnosis of eventration and differentiating CDH per se on the right side, because you'll have liver that's there. It can be very, very difficult, even on the left side. And ultrasound is not a good method to differentiate some of these things. In particular, what I'd say is that if you have eventration, you want to diagnose it and differentiate it from, a diaphragmatic hernia, because bowel will actually be below the level of the diaphragm. While there's eventration, it's difficult to sometimes pick up the diaphragmatic tissue in between, is really made by fluoroscopy or by actually doing a CT scan. Now, we have non-respiratory causes, and we should think of that in the sense we have done a lung ultrasound and it's normal, and really we don't quite have an explanation for it. But if you're kind of thinking of these pathologies, common pathologies, keep it simple. Keep it very, very simple. And when I say keep it simple, these are kind of the criteria that we're using to make the diagnosis for any baby. Now, for RDS, we spoke about a B profile with subpleural consolidations being a hallmark. This can vary from just mild subpleural consolidation to a frank snowflake sign to a frank snowflake sign with atelectasis to what is very severe atelectasis in the posterior parts of the lung. But you may, in the early phase, when you don't have a lot of surfactant inactivation, hyaline membrane disease, just have a presentation with AIS. And really, that AIS may be quite severe, and it may then confuse you with TTN. Now, I think if you start trying to make a diagnosis of transient tachypnea in an unsteroided 24-weeker, because he's got severe AIS without subpleural consolidations, I would say that clinical correlation would go against you. And I think that's where you have to be very, very careful. But again, transient tachypnea tends to present with a relatively regular pleural line, as opposed to it being a little bit on the kind of irregular side. It can be blurred, it can be thickened, but the classical presentation would be a clinical presentation of a baby who's improving, who then evolves into having spared areas, some A versus B profiles, which we call a double lung point. But the early phase might be severe and you might have AIS and compact B lines. And really, you might need serial ultrasound for the diagnosis of both TTN and RDS. Naturally, for RDS, you'd want to give surfactant early. So the recommendation is to try and get a scan between 60 minutes to 120 minutes of age to try and establish that diagnosis. Now, this is one very important key take-home message. I cannot emphasize this enough. You can have RDS complicated by retained lung fluid. And really, you will have x-rays which are completely white, which have got fluid in the fissure. And that doesn't necessarily mean that just because you have a little bit of fluid visible in the fissure on the right side in an x-ray that looks pretty reticulogranular with air bronchograms, that you don't have RDS. Actually, you can have an overlap of both. And that's where I would say to you that, again, if you have a 24 or 25 weeker who's unsteroided, that overlap of features would actually, based on your clinical presentation, your FiO2, as well as the kind of clinical course the baby's taking, prompt you to give surfactant. And that might mean that a proportion of babies who might have gotten away with CPAP get surfactant. And that's the nature of any investigation, whether that's a chest x-ray or lung ultrasound. So don't try to always, that perfectionist in you might try to kind of second guess yourself and say, I'm sure this is RDS. I'm absolutely certain this is TTN. Actually, we know that they can coexist. And really, if some babies then end up getting surfactant because of that, don't beat yourself up about it. That's the nature of how we make diagnosis. Now, for pneumonia, again, an important thing is you can have a B profile, you can have lung consolidations that are patchy, that are large. You can have subpleural consolidation that's focal. But if you have dynamic air bronchograms with a fractal sign, supported by, I would say, clinical evidence of deterioration. Now, at birth, a congenital pneumonia might present with respiratory distress right from the start. But in a 3-day-old ventilated 25-weeker who's getting better, who was honeymooning, who suddenly develops an increasing FiO2 with temperature instability, you do a CRP and that's gone up from, I'd say, 3 to 10, you see a fractal or a shred sign. Again, the focal nature of pneumonia in that case would be a giveaway. Usually with RDS and the subpleural consolidations, they tend to be more diffuse and affecting most regions of the lung, if the baby's supine, the posterior regions tend to be worse. We all know how to diagnose a pneumothorax now. I don't think any of you will have any trouble with doing that. But if you know these relative patterns and you can't see any of this and can only see a relatively A profile with good lung sliding, maybe with a few B lines and some kind of interstitial pattern, maybe, an AB profile predominantly, and the baby has respiratory distress, then just be aware that this could be perinatal adaptation, transitioning lung in the first few days, but sepsis can never be excluded. And group B strep can present very, very much with an A profile, with respiratory distress in a baby who's acidotic, who's basically tachypneic because he's got metabolic clearance. So again, at least in my setup, I don't think we'd risk it for any baby at birth. They'll all get antibiotics if they have respiratory distress. I know that some units in the UK practice a kind of a 4-hour cutoff for their near-term and term babies who don't have risk factors for sepsis. I think you have to do that based on your kind of bacteriological profile. But taking lung ultrasound into account and looking at all these diagnoses, I mean, the sensitivity and the specificity, if you use the criteria that we've just discussed for diagnosis, is very high. So, what I want to say to you is that really it's backed up by evidence as well. We're not really firing, arrows in the wind at blind targets. There are people who worry about the evidence behind uh, us being able to diagnose these clinical conditions. It's without a doubt very much evidence based from a large number of studies now recommended by the European Society of Pediatric Neonatal Intensive Care and the AAP. And I think for units who uh, kind of have any harbored worries about using lung ultrasound, I think they're completely unfounded. And I would not be surprised if, in due course, a lot of units adopt it, not just for the purpose of diagnosis, but also for quality improvement. Are these babies that we can keep with the mother? Because actually they are relatively well stable. They may start antibiotics, but actually don't fit a pattern of pneumonia or RDS, look more like a transient tachypnea. Those are babies who might not necessarily need admission to your unit. If you look at the agreement between lung ultrasound and chest X-ray in studied neonates, I mean, this is just a work that's been done by Rania Ismail and her group. And I mean, there is, very good correlation. I would say that for a diagnosis of RDS, pneumonia, transient tachypnea, uh, meconium aspiration, there is a higher sensitivity of lung ultrasound versus chest X-ray. I'd just be a little bit cautious about CDH because of the difficulties you can have with bowel. I think if it's antenatal CDH that's been diagnosed very, very early on, you have a significant amount of bowel in the chest, that's okay. But we have a lot of cases on the postnatal ward who might have postnatal diagnosis where bowel was actually in the abdomen but slides in and out. And just be aware that that is a diagnosis that can be missed. Pneumothorax, again, very high sensitivity and specificity, even for small quantities of air, which X-ray will just not be able to pick up. And then we have atelectasis. Now, for us, what is important is that we follow our protocol. We follow a step-by-step approach. And that basically means you review the bat wing, you review your pleura, you review your A and B lines, and you talk about what profile you think the baby has. And then you make a differential diagnosis for that profile after you have done anterolateral scanning, if and where clinically indicated, or a comprehensive scan if it so demands. If you're not following this protocol, there is a very real risk that you may not look for a batwing sign and you might see something that looks like a pseudo lung point. And that's why I've shown it to you today. Now, putting a needle in a baby because of that can be quite, I would say, risky because you'll then create a pneumothorax. The baby might actually get worse. So again, this is really important. But what is very important is that you mentally model. Well, I've got a history here. What is the indication for which I'm doing the lung ultrasound? Is it anterolateral or comprehensive scan that I'm going to do? If I do an anterolateral scan and I do not pick up the answer for my diagnosis, I need to do a comprehensive scan. If I do not pick up something that meets the eye with a comprehensive scan and the lungs look relatively normal, I need to think of alternative causes of why this baby is symptomatic. I need to make sure that I think of the heart. I need to make sure that I think of perinatal adaptation or pulmonary hypertension. And if everything is normal and I still have respiratory distress, then really the question is we need time. We need to think of other causes. And, you know, I'm just going to let you know that we've recently had a baby with respiratory distress who was eventually diagnosed to have congenital methemoglobinemia, which is a very, 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 very rare cause. So, sometimes everything can be normal, and it's a gas that basically picks up that there is trouble. So, now what we're going to do is we're going to practice, and we're going to practice in pairs. So what I'm going to do is I'm going to get Satish, Dr. Somasetti, and Sarvesh. Sarvesh, are you able to join us? Are you able to talk to us? Okay, Sarvesh is not there. Maria, are you able to join us?
Yes, yes, I can.
Perfect. So we've got Maria and we've got Satish. So we're going to let Maria have a go first. Now, we're practicing mental modeling over here. Mental modeling basically means that, Maria, we're going to have a look at images based on a history. You're going to talk through them. You're going to make your profile, your relative differential diagnosis, and then you're going to ask Satish for a second opinion. And we're going to see to what conclusion you come. And then really we'll come and have a chat about what we think the diagnosis was. So this is a term baby. This baby basically delivered by elective cesarean. This elective cesarean was because this baby was 5.4 kilos and a breech. And I think the worry was significant risk of cephalopelvic disproportion, obstructed labor. So the choice was offered to the mother. The baby was born. Steroids weren't given to the mother antenatally because clinically there was worry about the risks of steroids based on recent work that's been published. But the baby was tachypneic at birth. The baby had spot saturations done and saturated about 90 to 92%. So kind of an agreement in principle was we're going to give this baby a little bit of time after giving him some PEEP. So the baby was given PEEP for about 20 minutes, continued to have significant respiratory distress and grunting. So was then admitted to the neonatal unit. And the FiO2 initially was 30%, but at 2 hours of age, this baby has significant respiratory distress, respiratory rate of 80, is in an FiO2 of 40% on CPAP PEEP of about 7. This is the initial gas that was done at 1 hour of age, which was a pH of 7.25 and a CO2 of 8, which works out to be about 60 in millimeters. You have a lactate of 4. The baby was screened and started on antibiotics. The plan was to do a chest x-ray, but the radiographer is stuck, and we've done a lung ultrasound. Anything else you'd like to ask me?
Sorry, Alok, can you just at the beginning, did you say mom was in labor?
No, this is an elective cesarean for breech done
Okay.
during daytime hours, basically
Okay.
because of, so mom is not in labor, no.
Okay.
So would you like to see the scans?
Yes, please. Yes.
Lovely.
Alok, you did say term. Is it a early term or term? Is it like 37 week or is it like 40?
37 weeks.
37. Okay, thank you.
Yeah. So I'm showing you an anterolateral profile at the moment. So I'm showing you the left side first. Examination was equal air entry.
Oh, yes, I want the examination. Yes.
So equal air entry, just significant recession, grunting. The baby has very audible kind of expiratory grunt. We haven't done a translumination yet. So
Okay. So in L1, I can see the ribs and I can see the back sign. The pleura is continuous, sliding, and I think it's regular.
very good.
So we've done the lung ultrasound because we're waiting for the chest x-ray. Sorry, I should have started with that. Why are we doing the lung ultrasound?
That's correct, because we're waiting for the chest x-ray and the baby has respiratory distress. So
yeah. So I've gone through, I know I have the bad sign. I've gone through the pleura. So I can see, I think, L1 has an AI pattern.
Anything before that that you wanted to comment on in terms of the pleura? Sliding? Present, absent?
Oh, sorry. I thought I said that. I think
My
it's
apologies.
sliding.
I'm so sorry.
Yeah.
Yeah.
No, I might have not said it. But I think it's sliding.
Okay. Fair.
Yeah.
Yep.
Yes,
And
it is. No, it's
yeah.
not.
No problems. Let's see what your colleague thinks. But what
Yeah.
about the profile?
It's like being at work because I work actually with Satish.
Okay. Amazing.
Yeah, and the profile, I think it's an now I think there's a lung point. The profile is an AI pattern, I think.
Okay.
Satish,
Okay.
what do you think? I'm pretty sure there's a lung point.
Okay. In L1 or L3?
L1. It's not a double lung point, but isn't it a...
So Satish, you gonna help Maria?
Yeah, okay. Thanks, Maria. Yeah, Alok, like Maria said, I think we are colleagues, so it does sound like, you know,
At work.
at work, yes. Okay. L1, obviously, Maria has already said battling sign and pleura. The depth is appropriate for a 37-weeker. I think that's good. The pleura, there appears to be, you know, lung point, like Maria said, with a truck sign just about coming under the middle rib, I can see.
Okay, fair. In L1?
In L1, yeah.
Okay, okay. Okay, that's great. And what about L3?
I will let Maria go first. L3,
Yeah, go
Maria,
for it.
do you want
Go
to?
for it.
Yeah. So, yeah, okay. So L3, I think these are ribs.
Yeah, you're absolutely right. It's poor alignment. So the image could be optimized by getting a little bit better alignment at 90. It's poor alignment. So, yep.
But here the pleura is, I think it's less, it's I can't see it sliding as well as L1. I don't know what, but I can see more, or saying that I can see more A lines here.
Yep. Satish, you agree?
Yeah, I mean, you already said, I think it's better alignment would be good. There are some comet tails, I can see. So it's, yeah, agree.
Yeah, so some comet
There
tails.
are some subpleural, I think, consolidations, I think, where your marker was, if you want to, I don't know, sorry. Yeah,
So
there, yeah.
that is probably a comet tail.
Is okay.
Yeah, so normally what we'd say is subpleural consolidation should be more than 5 millimeters. They'd be very small. So this is more a comet tail. Again, this is more a comet tail. And you can just see a comet tail coming in there. Now, if you have comet tails, what does that say about sliding?
I mean, comet tails rule out air leak essentially. So that means the sliding is present.
Okay. But if there's any confusion, what should we do?
You do M mode.
Okay, so let's do an M mode. So what do we think about the M mode here?
Yeah, that's normal. Sure.
Sure, yeah.
Okay.
Agree.
Okay. So for all practical purposes, if I say that L2 is the same, and really, again, what I'd say is that if you look at the left lung, so a little bit worried there might be an anterior air leak, possibly, but I've not shown you the M mode yet. But let's look at the right lung as well. Let's just see what we think.
Okay, so R1, yes, I can see the ribs. There is the pleura is sliding. I can see comet tails. Yeah. A lines more, yeah, A lines here.
Yep.
Where you're pointing, but also there are B lines more on the left. side of the image, I mean.
Okay, so very, very important. These are both R1. What is the difference between the image on the left and the image on the right?
The image on the right is better, the probe is better aligned, I think.
So, so this is in the intercostal space. Can you?
Personally.
Yeah.
I
So
think and the one where you're showing the marker, I think there is no batwing sign. I think it's between the intercostal space. The one on the right hand of the picture is where you can see clearly batwing sign.
very good. So basically, it's the difference between having what we call as perpendicular scanning versus horizontal scanning in each intercostal space. So I'm showing you the same image. So on the left side, do you agree there's sliding?
Yes.
Okay. And you've got a B profile.
Yeah.
And then you've got this area over here, which is
A.
A. Do you think
A.
there's sliding there?
There is no sliding. I would really
No.
like to do a mode there, Alok.
Okay.
I
Lovely.
think on the right hand panel you can clearly see the truck sign.
So R1 again.
Yeah.
Truck sign.
Yeah.
Sliding. Yeah.
Well, it's a lung point, isn't it? I think where just you're showing your marker.
Very good. So lovely. So I mean, we were confused about L1, weren't we? The question is whether L1 there was sliding or not, and whether there is. So how
Some
would we?
anterior early. I think L1 there might be some small anterior pneumothorax. We were thinking,
Okay.
weren't we?
So
Yes.
how will we find out? What should we do?
We can do the M mode there.
Okay. So now let me show you the M modes and let's see what you think. So this is L1.
L1 looks more normal.
Yep. Yep.
But R1 is a bit,
Yeah.
looks like a barcode sign, no?
Yeah. Yeah.
Yeah.
So
R1 is the barcode sign. L1 is normal. Yeah.
So basically L1 is normal, and you're absolutely right. If you look at R1 at this particular point, this is the lung point. So you've got a sandy beach here, and really you then have a barcode sign over here. Now, basically R2 and R3 had normal sliding. Everything was fine. So I've got a baby with some respiratory distress. What are your differentials now?
Well, I'm definitely thinking of a pneumothorax on the right side.
Yeah.
So I really want this X-ray done.
Yeah, no, absolutely. But I mean, we talked about those 5 diagnoses. So let's take them one by one. RDS. So do you have subpleural consolidations?
No.
Okay.
Not that are very visible.
Yeah. Then if I talk about just pneumonia in this particular situation, do you have any focal consolidation, focal patchy areas of consolidation?
No.
Okay. What about transient tachypnea of newborn?
I mean, like you all in every time I hear, I mean, very nicely, you always talk about clinical correlation, which is really pleasing to hear. I think that's something which is kind of lacking these days, I would say. Yeah, I think back to clinical correlation. So this is an elective cesarean section. Mother is not in labor. Baby is grunting. So I think we need to put all those into context when coming to the conclusion, I guess. So yes, that's what I would say.
So it's possible.
Yeah.
But actually, we've also had a baby on high PEEP whose FiO2 is kind of stuck at 40. So what I'd say is that really it kind of goes against it once you've done the lung ultrasound, because you've clearly got, now this image that you see here with R1, this is the lung point. So you've got the pleura moving here with what is basically a B kind of profile. And this is basically your A' profile. Truck sign, pleura is not moving, A lines. And this is basically how it looks on M mode. So really what you've got is you've got a small right anterior pneumothorax. Management, because it doesn't extend to R2, R3, it's not going far forwards. What would you like to do?
The big question about CPAP and pneumothorax.
Very good.
Different neonatologists will have different views on that.
It's the beauty of being a neonatologist. So, I mean,
Yeah.
there's an option. Is your gas is not too bad. CO2 60. What about just putting him on some Optiflow?
I would do that.
What do the others think? Anybody else with a different view?
To lie down in the right side.
Okay. Anything else that'll help? I mean, that, you know. So, does
I
anybody
mean,
think we should treat?
give. I mean, sorry to interrupt, Alok. Give some time. I think put the baby on Vapotherm high flow. It's a big baby, so you could go for around 8 liters or something.
Yeah.
Put the baby prone, minimal handling, and then I think reassess in a couple of hours to see which direction the clinical course takes.
Yeah.
Hopefully by then you would get the chest X-ray to see whether this pneumothorax is limited to just anterior air leak, whether it's anything more than what we have already gathered from the lung ultrasound. And then come back to clinical correlation to see which way the baby is going to go. If the baby's worker breathing continues to settle and the oxygen requirement slowly starts to come down, if the gas exchange is acceptable, then I would sit tight and watch.
Lovely. So, anything else? So, let's say you want anything else that you can do. You do a chest X-ray. It's a small anterior pneumothorax. So you can repeat your lung ultrasound. And this is just the repeat lung ultrasound after 2 hours. Baby still had significant respiratory distress. So what do we think now?
Oh, now it's in R1.
So it was in R1.
It was in R1 before as
Oh,
well.
it was in
with
I
R3.
mean, now it's in R3, sorry. Because
Yeah.
both of
And can you see that there's no sliding at all in R3?
Getting bigger.
Oh,
So
yeah.
if you see the top image, I mean, there's no sliding. It is an A- profile, and
Yeah.
you've got a barcode sign. Now, naturally, from our perspective, that might be an indication for treatment, but in this case, we actually decided not to. And we gave the baby a little bit more time, just managed conservatively, and actually the baby was stable and didn't need any intervention at all. So serial monitoring is crucial, but no worsening of respiratory distress. The gas was also getting better. So even with progression from R1 to R3, I think the feeling was at that particular point to continue conservative management. But I think if you'd kind of seen that going backwards to R5, R6, once it heads towards the posterior axillary line, and if the baby has respiratory distress, you're in trouble. Again, during your early management, don't hesitate to go clinically, get a chest X-ray, and really, with time, what happens is you'll become more confident using lung ultrasound. Any questions about that case?
Look, so
Yeah.
after your first lung ultrasound, did you put the baby on high flow?
So yes, we put the baby on Optiflow and put the baby prone, but we
Okay.
used about 6 liters. So
Okay.
over here, I mean, where I work currently, we use even higher flow rates as compared to just using plain Optiflow. We don't use Vapotherm. And in Southampton at that time, we didn't have Vapotherm, so we just went on to Optiflow.
Okay.
So the next case, Jafar, are you able to join us?
Yes, sir.
Amazing. So we'll have Jafar and we'll have Sarvesh. Can you hear me? Sarvesh can't. Dr. Satish Kumar?
Yes, yes, sir.
Lovely. So Zafar will go first, and then he might need your help, Dr. Satish. So we have a preterm 33-weeker who delivered spontaneous onset of preterm labor, no known risk factors for sepsis. The mother was basically in labor for about 30 hours. So it was quite a prolonged kind of labor. The first dose of steroids was given, but the baby delivered before a second dose of steroids could be given. And really, right from birth, the baby had quite significant respiratory distress, subcostal intercostal retraction. The baby kind of was managed with a little bit of IPPV to start off with. And after about 5 minutes, kind of baby stabilized. Work of breathing actually became a little bit less, so the baby was managed on CPAP. PEEP in delivery suite transferred to CPAP and is currently on a PEEP of about 7. FiO2 is 30%. The baby's kind of had its golden hour management, had a peripheral saline culture, antibiotics, but has significant work of breathing. The initial blood gas is a pH of 7.25 again, and your CO2 is about 60. Any other questions?
Second blood gas at what hour of life, sir?
Sir, golden hour ke baad, we've just done one blood gas. So the pH is 7.25, CO2 is 60, base is -4, lactate of 3. Blood sugar is fine. We haven't repeated another gas.
What about PO2, sir? And
So it's a capillary gas. The PO2 is not quite reliable. We haven't put arterial lines in. Jeffrey, anything else?
We can say it is persistent respiratory distress is there.
Yeah. Baby is about, I'd say coming to about 90 minutes of age now. So we're doing a
Yes.
lung ultrasound, basically, because we're worried about the potential for the baby having RDS versus TTN. That's the indication. Could have a pneumothorax as well, but translumination test is negative.
Okay, so
Yeah.
babies on CPAP and PEEP of how much?
7.
Okay.
Should I show you the scan?
so we go for a scan.
Yeah, we've gone for a scan. So this is your right side. -90 minutes of age. This is R1. So if I just label them for you, R1, R2, R3, R4.
So sir, that R1 is showing B profile with little bit A profile also there.
Yeah.
We can say that at least more three space is showing B lines. A lines is also there, but prominently there is a B lines.
Okay.
Same. Yeah, this one.
Okay. What about R2?
Yeah, here there is same. There is a little more A lines and less of the B lines.
Sure.
The
Oh.
lung pleural sliding is also there. There is some in R1 there is some microatelectasis, or we can say there is a subpleural consolidation also there in the R1 comet cell signs.
So the definite comet tail signs over here, but yeah, this area does worry you about the potential for
Yeah,
subpleural consolidation.
yeah, there is a consolidation is also there anteriorly upper R1 side.
Yeah. Okay. So R1, R2. Now, what about R3 and R4?
Yeah, R3 is also showing sir some subpleural consolidation and more of a B lines with less of A lines, and there is a subpleural consolidation in R3 as well.
Okay. R4?
Yeah, there is a prominent B lines, but A lines is also there, and comet tails is also there in the
Okay.
R4.
Okay. So you're just looking at the right lung at the moment. So, I mean, clearly we have double lung points because you've got aerated lung in the middle with a B profile. You've R1, R2, you definitely have lots of double lung points. And R4, actually, is a decent well aerated lung. So, do we think this is transient tachypnea of newborn versus RDS?
So after 90 minutes of life, it is also showing more of a B lines. It could be RDS rather than TTN, because with time TTN will improve. So we can repeat the lung ultrasound after 1 hour.
Okay. Okay, that's good. Now, my only comment is, have we done the left side? Should we have a look at the left side?
Yes, sir.
Okay, so now let's have a look at the left side and see what you think.
Mm,
What do we think? So batwing sign, pleura, regular, irregular,
irregular pleura is there on left side.
sliding,
Sliding is also there. Sliding
yeah,
is there.
yeah, profile,
B.
subpleural consolidations,
Comet tails is there. Yes, it is there. Some subpleural consolidation is also there
yeah,
on
yeah,
L1.
yeah. L2 is a poor image, and the reason I want to show you this image is because the heart is coming in between. And really, what we need to do is we need to move the probe. There are two ways. Like, the reason I want to show you this image is if you can all have a look at me. So if you're on L2 and you're struggling to see lung, the best way to kind of look at it is to move your probe a little laterally into the anterior axillary line and try and basically keep it perpendicular. And that will give you lung tissue. Or move it a little bit medial to try and get the heart out of the way. So don't feel too stressed, but the diagnosis, if you're not able to get L2, is, it's not just made by not being able to view one area. What about L3?
It is more or less same like L1, sir.
Yeah.
More of B lines, subpleural consolidation, and there is a consolidated B lines is there.
And what about,
Irregular pleura is there.
okay, what about L4?
Mm, yeah, sir, irregular pleura and more of a B lines with comet tails is there.
Okay. Okay, so now we've got a group of people. So what is your diagnosis, Jafar and Dr. Satish? What do we think? So if we go back to the baby, 90 minutes old, FiO2 is about 30%, pH of 7.25. This baby basically has a CO2 of 60, but has got significant work of breathing. No evidence of a pneumothorax in the anterolateral regions. This is not a comprehensive scan. Baby is grunting, recessing, working hard. Is on a PEEP of 7. So what is
Yeah,
your diagnosis?
with this clinical picture of increased work of breathing, progressive increased work of breathing, and high PCO2, and with more of B profile with the subpleural consolidation, probably go in a preterm baby, and probably will go in favor of RDS, I think. But the double lung points in lot of the picture, double lung points are there in lot of picture. Maybe because of the CPAP,
Okay,
based on CPAP.
okay. So Satish, that's beautiful. What you're doing is, so can everybody see this is mental modeling? A description of the clinical presentation, clinical course, clinical support the baby's on, and really from our perspective, the lung ultrasound appearances in correlation. Uh, what do the others think? I'm curious to hear from everybody. How many people think this is TTN? So if you could just put it in the message box.
Could be neonatal aspiration syndrome.
No meconium, sir.
لا neonatal aspiration will make amniotic
Yeah,
fluid.
could be.
Maybe.
It could be. Uh, Again, what I'd say is that it's a very diffuse, homogeneous kind of picture.
Yes, sir.
So with such a diffuse, homogeneous kind of a picture, I would find it hard to kind of convince myself about like aspiration uh, or blood aspiration. There's no history to suggest. My question now at this particular perspective is, does anybody think this could be TTN? That's what I'm really keen to hear.
Due to frequent consolidation, macro subdural consolidation, I think there's no TTN here.
Okay. So how many of you want to give the baby surfactant?
Lung score not high.
Yep, you're right.
Will
So let's score him. Let's do that. This is a very, very nice case that I like for this reason. So let's score him. So R1, R2, R3. One sec. Yeah. So R1, what score are you going to give, Dr. Ashraf?
Like in the lateral view here, sometimes AIS and more than two space here, and 1 to 2, but 2 because they have sublock consolidation. It's 2 here
Okay, so that's 2 plus. I mean, I
plus
think you could argue 1 to 2. Some people might, but I would say I'd probably give R1 and R2 a 1,
uh,
but definitely give R.
lateral 2. Yeah,
Yeah, no doubt about it. So that's 2 plus 2, 6. Sorry, 2 plus
plus
2,
2,
4.
4.
Yeah,
Yeah,
4. My apologies. My maths is not good. But what about the left side?
more score. This is one more score. This is 2,
Yeah, easily 2.
2.
No atelectasis. I'd say 2 everywhere. So that's 6. So 4 plus 6
Yeah,
is 10. So it favors
10.
giving the baby surfactant. Now, this, I mean, from our perspective, was very classically a case of respiratory distress syndrome that we treated with surfactant based on the lung ultrasound with clinical improvement in the baby. So again, just an example from our perspective of how uh, you can use lung ultrasound very early on, even before getting a chest X-ray to decide on whether you want to give the baby surfactant. So it was
But look,
really,
but
yeah,
most of the few have well aerated lung, well
yeah.
aerated area.
But as Satish has mentioned, you're CPAPing this baby. So because you're
Uh,
CPAPing this baby, now what we know is that often the right lung tends to aerate better than the left lung. So on clinical correlation, with that kind of work of breathing, we preferred to give this baby early surfactant than wait because we were using a high PEEP. And again, just extrapolating data from the COIN trial, the COIN study, the risk of a pneumothorax once your FiO2 is kind of approaching, I'd say 40% goes up. And, in this case, we did have a rising FiO2. It went up even further. So we went for LISA in this case with, a decent effect. Again, what I'd say to you is that kind of argument of double lung points and aeration spared areas, please be aware it is not pathognomonic of TTN. The presence of subpleural consolidation should always raise in your mind the risk that you've got RDS. And then I would say please clinically correlate because there's always an element of overlap that you might see in these babies. Babies who are being peeped in the delivery suite, we've altered the natural history of RDS by kind of introducing a lot of delivery room intervention. So very important. So this is going to be our last case for today. Just looking at the time. Now, we've got a few minutes very quickly to do this case. So a 36-week baby at 2 hours of age has acute onset of respiratory distress. The baby was admitted with mild respiratory distress after normal vaginal delivery, had risk factors for sepsis in the form of PROM, and from our perspective, kind of had a little bit of optiflow. So gases were okay. The CO2 was about 50, pH of 7.3. So this is our X-ray with the acute deterioration. Sorry, my apologies, the lung ultrasound. So this is R1 that you can see. Anybody can comment.
I see the rib there وفي maybe lung not sliding well, double polar not sliding well. في track sign.
Yep,
Mainly A profile, A dash profile.
yep.
Yeah, I have this also there is no lung sliding. في some column here.
Why am I showing you 3 images of R1, sir? Anybody? Any comments from anybody?
To try to get the lung point, if it is lung point.
So they're all the same spaces, really. So what I'm showing you is image optimization over here. So if you look at the image right at the bottom, it's not so good. It's poor quality. I think in particular, what it exemplifies is that the pleura is quite irregular. It looks a little bit thick in regions. Very poor delineation of whether they're A lines. And actually the question is, are there B lines that have broken this A lines? Is this a B profile? Is this an A profile? And the reason this is the case is because I'm using a very low frequency. Now, naturally, the abnormal frequency with that particular depth is not giving me very good depth penetration either. Just again, what I've done is I've increased the frequency here to about 8, and now I'm using a frequency of about 12 in this particular region. I'm losing a little bit of depth over here because I'm using a higher frequency, but can you see how the quality of the image improves? Now, we've got a batwing sign, we've got ribs, intercostal spaces, sliding.
No.
But you have comet cell archetype.
Yeah, that is the challenge. Sliding or no sliding, we don't know. We're not sure. We have comet tails, but so
We have lung about board in this area and the one in the
Barcode
right corner. We have lung point here.
which
Sliding
side?
in
Which side?
here
Here or
is this
here?
one. Yeah, this is lung sliding here in the more the right the screen.
Yes.
Yeah, this is here in the old marker.
Yeah,
This is like sliding here.
yeah.
In the left side, no sliding.
Okay, so there's
I
a
think this
real
lung point here.
concern, but you do have comet tails, Dr. Ashraf.
We have
So
commentary.
we shouldn't have comet tails. So it's confusing. You have a little bit of a truck sign as well. Now let's see. So our plan is always, if we're confused, we're going to use M mode.
Mode.
So let's show you the M mode. What do we think?
Feel confused.
It's tough, isn't it?
Yeah.
Okay. Anybody confused? I can see clear sliding over here everywhere. I think there's sliding. That's my opinion. But the M mode is a little bit confusing as well, because it looks like there's a seashore sign over here, and it looks as if there's a barcode over here. The question, obviously, from our perspective is, it's a little bit confusing, but let's look at the opposite side. We've seen R1. If I say to you that, from our perspective, R2 and R3 were very obvious for having no evidence of a pneumothorax, completely A profile with sliding and seashore sign everywhere. Let's look at L2. L1, L2. So what do we think?
Normal better.
Very good. Very good. Normal pattern. Okay. Again, the images at the top are not very good quality, low frequency, and this is just to kind of show that you can optimize that by actually increasing your frequency. I'm losing depth because I'm using high frequency, but just in terms of pleura and A-line delineation, it is, from my perspective, so that's a still image. Okay, so I'm showing you L1, L2, which are relatively normal. What about L3?
You have sliding as well.
Yeah, sliding, comet tails, B profile. And if you look at the kind of seashore, absolutely clear seashore, the real confusion is this image over here with R1. It's a really tricky one from our perspective. So I think the overall feeling was there is a small anterior pneumothorax in R1 over here. And it's a very difficult one. When we picked up and did the chest x-ray on this baby, we had a very sharp border on the right side of the heart. Now, when I discussed this case with Nadia, her view was very much that sometimes you get these anterior bubbles that give you this kind of an appearance. And that whilst you can see comet tails over here, there are not a lot of comet tails in this particular region over here. And you might just have a small bubble, again, where you have a truck sign. And can you see how prominent the A profile becomes? It becomes maybe an A- profile in a very small focal area of the lung, which is giving you this appearance. So near the meatus, the kind of lateral sternal border on both sides, it's not unusual for you to pick these up. And I'll send you an article today that basically shows you how you can use your probe and position it to try and get a clearer picture of whether it might be a pneumothorax or not. If there's confusion in situations like this, I always phone a friend. I'll get somebody to have a look at the image. I will clinically correlate. And please be aware, if I'm confused, I'll get a chest x-ray. No, absolutely no doubt about it. Any questions? I hope that's helpful. I think my key take-home message from the workshop today is that your mental modeling, clinical correlation, absolutely key. If you're confused about sliding in situations, go back to your M mode. There will be the occasion where you're still confused, phone a friend, get them to come and have a look. If confused and you have, get a chest x-ray. I think from our perspective, there's absolutely no doubt. Anybody who comes and says to me that the role of chest x-ray is completely out or finished, uh, they're living in cuckoo land. I think what I'd say to you is that the chest X-ray is still very much needed, and I think as you become more confident, you'll develop your own judgments about which babies you will feel comfortable not doing it, versus babies where you feel comfortable that actually you've done the lung ultrasound and it gives you the clinical correlation to make a decision. And then there will be some babies where you're confused. Just if that is the case, default back to an X-ray. Use both of those modalities. God bless you all, and thank you for your patience and hard work. Thank you so much.
Thank you.
Thank you.
Have a good evening.
Thank you. Thank you.